Welcome to my policy presentation on why fertility preservation should be provided to American Indian, Alaska Native adolescent and young adult patients receiving cancer care at Mayo Clinic. Hi, I'm Sam, and I'm a patient navigator for adolescent and young adult patients with cancer at Mayo Clinic, Arizona. Mayo Clinic has recently created a program to provide an additional layer of comprehensive support to its AYA population. Mayo Clinic recognized that in order to provide the best care to our patients, we needed a specialized team that would be able to provide age-specific care. Historically, the majority of cancer care has been geared towards pediatric patients, and everyone else has been lumped together. AYA patients face unique challenges when dealing with a cancer diagnosis, such as relationship dynamics changing, school and work considerations, financial and insurance implications, and fertility preservation. As a patient navigator, I specialize in providing resources to our AYA patients. This includes transportation, lodging, financial assistance, grants, and I also help navigate complex insurance issues as well as connect them with the rest of our AYA team. Oftentimes, AYA patients are tasked with making crucial decisions regarding their care, such as fertility preservation, in a short period of time, with finances often playing a huge factor. Since the majority of insurances, both private and state-funded, do not cover any costs associated with fertility preservation, some AYA patients are unable to move forward with the preservation process, even though there may be a strong desire to do so. I have had to witness many heartbreaking conversations with AYA patients who could not afford to have fertility preservation and thought something needed to be done about it. Mayo Clinic is a nonprofit hospital system, meaning they have a duty to care for the community they reside in. However, they generally do not accept state-issued Medicaid, also known as Access, without prior department approval. The one exception to this rule is the Access American Indian Health Plan. American Indian Alaska Native patients that have this health plan can be seen at Mayo Clinic without needing prior authorization. Access American Indian Health Plan currently will cover all costs for American Indian Alaska Native patients seen at Mayo Clinic. However, there is no coverage for fertility preservation, even with a cancer diagnosis. In addition to providing quality health care to American Indian Alaska Native patients with Access American Indian Health Plan, I propose Mayo Clinic go one step further and provide fertility preservation to their AYA population being seen with a cancer diagnosis. This includes egg retrieval or sperm collection, as well as preservation. Mayo Clinic will pay the annual storage fee for a total of 10 years after treatment ends for patients 18 to 29, 5 years after treatment ends for patients 30 to 40, or when patients use their sperm or eggs, or when patients decide they do not want to use them and want them destroyed. Mayo Clinic's core values are called Rich Ties, and the S stands for stewardship. My policy fits into this model because part of the Mayo Clinic's total expenses must go towards charitable services, being a 501c3 organization. Mayo Clinic is also dedicated to providing health care to historically underserved communities and addressing healthcare inequality gaps. It also makes sense if you look at the numbers. In 2023, Mayo Clinic Arizona saw 12 American Indian Alaska Native AYA patients, 7 of which who were women and 5 were men. The average cost of male sperm collection is about $500, while the average cost for female egg collection is significantly higher, around $5,000. Annual storage costs are about $600 annually after the first year, which is included at the time of collection. The AYA program directors will present this policy proposal to Mayo Clinic's policymakers. It is important in the policymaking process to utilize Deborah Stone's model of reasoning. There are 5 main objectives in the model of reasoning. The first being identifying objectives, and that would be having our policy actually be approved. The second is identifying alternative ways this policy could be approved. Where would the funds come from? Private donors in the development department or through the Mayo Clinic itself? The third is to predict consequences of each way funding could be achieved. The fourth would be to then evaluate the consequences of each way funding could be achieved, and the final being identify the best alternatives. This model will also be utilized throughout the decision-making process for all aspects of this policy. Because this policy is being presented at an organizational level and not through the state legislature, there are two policymakers that share the responsibilities: the CEO of Mayo Clinic Arizona and the Mayo Clinic Board of Governors Executive Committee of Board of Trustees. Whenever you are making policy, it is important to consider who may be against your policy and why. The Chief Financial Officer could be against my policy due to how much money it will cost Mayo Clinic over time with the collection and preservation fees. The Chief Legal Officer could be against my policy if they feel there could be areas that leave Mayo Clinic exposed to legal repercussions. As current state laws around cryopreservation change, the CLO could also be more against it. The Chief Compliance Officer could also be against my policy because this is uncharted territory for Mayo Clinic. Because we would also utilize an outside preservation facility, the CCO could have concerns about how things are handled there and what implications it could have for Mayo Clinic. Just as it is important to know what stakeholders are potentially against my policy, it is also important to know what stakeholders are in favor of my policy. And the stakeholders in favor of my policy, first and foremost, are the AYA department. We are represented by our program directors. The Center for Facility Studies are also stakeholders, as they are going to be performing the collection and doing the cryopreservation. The providers performing the preservation will also be the stakeholders, as well as the chair of the development department, since there is a chance this policy would be funded through this department. Since policy happens incrementally, I wanted to start with a small specific patient population. Originally, I did not think about storage timeframes, and I also realized that guidelines were necessary when creating this policy. It is not sustainable to have preservation being paid over the course of 20 years, only to have it potentially not utilized at all. The AYA team will be the primary consumers, as we are the ones that really want to see this policy be implemented. And we will also be the primary advocates. By engaging in the community and with other providers, we can help promote our policy. Future policy innovations include expanding the program. There are more underserved communities that would also benefit from this policy. With expansion would also come with revisiting eligibility criteria. It is possible that we would need to add more criteria, including exclusions for those AYAs that already have children, and also shortening the preservation period. With the growth of the AYA program, this policy would expand with it. When the policy expanded to another site, so would the program. AYA patients should not be forced to forego fertility preservation due to financial circumstances. Given that Mayo Clinic wants to help American Indian Alaska Native patients receive better medical care, this policy aligns perfectly. By utilizing this policy specifically for American Indian Alaska Native patients with a cancer diagnosis, this is also a financially manageable policy with room for incremental improvements. There are also multiple avenues for funding from the development department as well as through Mayo Clinic under a charitable donation category. Thank you for taking the time to listen to my innovation project.